בוקר טוב לכולם. לפני הצגת המרצה, אני מבקשת לומר מספר מילים בקצרה, שמקווה שאצלח עם התרגשות קלה בלבד, ותסלחו לי אם לא. אני נפעמת כנראה כמו כולכם לחשוב מה היה כאן לפני מספר שבועות, ושמחה על היכולת לחזור למסלול ולקיים את הכנס. אבל באותה נשימה אני מבקשת שלא נשכח שהחיים לא המשיכו כרגיל אצל כולם. אני רוצה לשלוח חיזוק ענק מכולנו למשפחות שחלקן כאן, שבניהם יצאו בתחושת שליחות עצומה להגן אלינו ולא חזרו, ולאחל להם שמי ייתן וימצאו כוחות להמשיך ושיזכו לזמנים של חסד ונחמה, ולאחל למאות הפצועים שחלקם יהיו בשיקום בזמן ארוך, שיקום מרבי ומוצלח. כן. עכשיו אני צריכה לנשום. I'm honored to present Professor Robert Palisano, one of the most influential researcher in the pediatric rehabilitation world in the last few decades. Professor Palisano is a researcher in Drexel University, Philadelphia, and he is a senior member of the Ken Child Group at McMaster University, Canada. His work influenced therapists' clinical work all over the world. The development of GMFM and the GMFCS, the focus on measurable, individual, meaningful goals in therapy, the importance of the child participation in life, and I can go on and go on. I want to thank you, Bob, on behalf of the participants in the conference for coming to Israel for the first time, especially after the complicated summer we had here. We do not take it for granted. Professor Palisano will lecture on pediatric rehabilitation services, New Horizons. Professor Palisano, please. Okay.
Shalom. It's an honor to be invited to present to your group, and I'd like to thank the NAVA as well as the entire organizing committee for extending me the invitation. I've also had a great opportunity and very much enjoyed to be part and to experience the culture and the history of Jerusalem. So I'm very fortunate to be here this morning. That's that's Philadelphia, our city hall, and my university is walking distance from there. So this morning, my presentation is based on the assumption that the desired outcomes of pediatric rehabilitation are meaningful participation at home, school, in the community, and quality of life, as well as preparing young people with the knowledge and skills for successful transition to adulthood. Two of my colleagues, Peter Rosenbaum and Jan-Willem Horter, recently published an article that I think reflects a lot of what I'm going to share this morning. They called it the F words. And the F words are, again, a new horizon, a way of thinking about children and about families. And they are function, family, fitness, fun, friends, and future. So I think I'll touch upon all of those in the next several minutes. But sometimes, if you look at youth, in this case, Tyler, I think he actually can say what I'd like to say much more eloquently. So I'd like to begin by sharing a little bit of Tyler's perspective. So if we could have the video.
Hi, I'm Tyler. Since you're here, I'd like to take a few minutes of your time to tell you a little bit about myself. I guess I'm just a normal high school sophomore. I love video games and movies, especially action movies with lots of martial arts. You know, Jackie Chan, Bruce Lee, Jet Li. I take karate lessons myself, the Shinkudo style. I'm a yellow belt with a blue stripe. I've got great instructors. They're called senseis in karate. I had to stop taking lessons last fall because of marching band practice. We've got an awesome band. Our director works us hard. I'll never ask more than your best, he always says. Last year, we were first place in large group state competition. This year, we had to settle for second, but we'll be back next year. Besides band, I like all kinds of music. Pop, rock, rap, hip-hop, even musicals. Andrew Lloyd Webber is my favorite composer, but I like the newer rock operas too, like Hero and Rent. I've been lucky enough to see a few on stage. I got the chance to be on stage a few times myself, at our community playhouse. I got the part of the kid in the Boxcar Children. 54 kids tried out for 6 parts. I felt pretty lucky to get one. Last year, I was in one of the high school large groups for state drama competition. We did the Dr. Seuss version of Romeo and Juliet. It was a lot of fun, but hard work. We got an all-state nomination. Quite an honor. Oh yeah, I do go to classes too. I have a 3.5 grade point average so far in high school, and I have to work to keep that up. It's pretty hard to get fired up about math, but my teacher's great. After school on Mondays, I have scouts. In fact, if you're watching this, which I hope you are, I'm an Eagle Scout. Doing this video is part of my Eagle Scout project. Well, I probably shouldn't bore you too long with my life, especially since, given the situation here, I can't let you return the favor. But before I go, there's one more thing I should tell you. You knew there was going to be one more thing, didn't you? Well, I'm not really Tyler. My name's Chase. I'm an actor and a friend of Tyler's who was very happy to help him out. Tyler's here too, but before you meet him, I want to assure you that everything I told you about him is true. All of it. That's Tyler's life though, not mine. And he'd be the first to tell you that he didn't get there alone. I think he'll want to talk with you about that. Come to think of it, do any of us get there alone?
I don't think so. Yep, I'm Tyler. Surprised? Why? You shouldn't be. Chase described the life of a typical high school kid. Well, that's me. Sure, I got a couple extra things to deal with, don't we all? Mine are cerebral palsy, nonverbal learning disorder, obsessive compulsive disorder, anxieties. They're all a part of my life, but I don't want to talk to you about that. I want to talk to you about the people who saw me, who made the effort to see me, Tyler, not my diagnosis. These are the people who saw me for my abilities, not my disabilities. I call it ability awareness. Sure, these people recognize my challenges, but they didn't let them be showstoppers. They just helped find accommodations to get around them. And yes, they took some extra time and energy from me, and I appreciate what every one of them has done. I can't imagine what my life would be like without them. Any of them. My cry instructor, my sensei,
We could
clearly seen me
stop the movie,
with
the
a
video
big
now.
cat.
Thank you. So, since you're so gracious to bring me here, I suppose I need to say something, or I could have had you watch the rest of Tyler. That video, if you would go to an internet and put "I'm Tyler," it is available for free. You can view it from the internet. So I think Tyler really has said much better than I'll be able to the idea of ability and not disability. So let me touch on four themes: enablement frameworks to guide our thinking, a life course approach, evidence to practice, and transformative services. So the enablement framework I'll touch on, and one that we use and I think internationally is now being used to guide ways of thinking, ways of communicating when we do research, is the International Classification of Function, Disability, and Health. Could I have just people maybe show of hands if you're familiar with it in your own work? So good. This is just an illustration. We work really hard, particularly with our students, that they use this as a framework to form their thoughts and not just a model. So I've just filled in some of the key points that might apply to individuals or children with cerebral palsy, and where all the arrows, in my own work, I'll use thick arrows to say at this point, at this time, and working with this child, these might be our emphasis. But as the presentation today, really you can see activity, participation, and then the contextual factors of environment and person, and you can see the interface there, and that really will be the focus of my thoughts this morning. So it's a biopsychosocial model, and the main message is that psychological and social factors need to be considered along with biological factors to understand consequences of a chronic health condition on a person's health and function in daily life. So the unique features that provide us a new way of thinking, a way of moving forward, are the emphasis is on components of health rather than consequences of disease. It integrates the social and environmental aspects of disability and health, and participation, which I'm going to emphasize, really makes us think of a person in an environment. We have to think of the combination in order to address participation. So participation, very simply, is involvement of children and youth in home, school, and community activities that are meaningful to them. In some of our work, and I'll present a little bit more later, we've talked about the concept of meaningful participation. So it's not just being there, and we've talked about it as having determinants and dimensions. So the three determinants, and you could see they're interacting, and it's a dynamical situation. So the child, both aspects of the child's health condition or disability, but other parts of the child that are unique to that child, the family, and the environment. These are the things that will determine participation. And then it's important to think about participation in its full scope. So the physical aspect, what the child does, and the social aspect, how are they interacting with peers, with adults, within the concepts or the constructs of the activity, and the self. And the self simply could be thought of as enjoyment, but we also think in terms of the learning aspect, it's the idea of doing something that is purposeful and meaningful. So if you're practicing to learn to play a music instrument or to learn a functional skill, the idea is that you are learning and there is some fulfillment, some internal meaning to that activity. So what are some of the perspectives on participation? Well, one, Alan Culver, who's done a lot of work, a Sparkle study involving 9 European countries, him and other colleagues have talked about participation being determined by a successful interaction of the person and the environment. And I think what's empowering upon that is we do know for many children there are some upper limits beyond which we can't completely change their neurological or psychological impairments, but that's not, but the environment as an enabling context provides us opportunities or provides young people opportunities to do the things they want. Second, that disability concerns the inability of the physical, social, and attitudinal environments to enable participation. So it's quite a flip in terms of thinking about disability is also something that is societal and not just what's the physical impairment. So what about a life course approach? As this slide indicates, young children do become young adults. Unfortunately, it took us, and I can speak for myself perhaps, but I think it took the rehabilitation community many years. I would argue it's probably not till around the mid-90s that we began to really realize, oh my gosh, these children we've worked with are now adults and they face challenges. So I think probably the world is united in terms of really at a point in our development as professionals in how do we optimize, how do we enable people to transition, how do we allow Tyler to continue to do the things he's going to want to do as an adult. So one of the things that I think is very useful is the idea of transition periods. So the thought is sometimes we have the sense of providing children with developmental disabilities services continually. And it's not to say that there isn't some levels of support, certainly there are education programs, but the thought may be that there are key transition periods where we may want to not just focus at the time, but anticipate. Some of the research that I'm involved with now, we have a part of our research project involves 7 parents living throughout the U.S. and Canada, and some of the things they've told us is they want to know what to expect, not only for what they can do now, but for how to anticipate. One of the parents, we meet via a teleconference. She says, "Oh, my son wants to talk. He's a 12-year-old child with cerebral palsy," and because we were asking, what do children want to know about their development? And he asked me, he had a question about being able to drive. So that's anticipatory guidance, thinking ahead. And I would argue that that's something we can really could embody better, and I think would be a great service to children and families. So I've just listed some of the key transitions that I think children go through. And the thing is, even though you may be with them for one epoch, if you're an early intervention provider or you see the child in elementary, families and children continually experience these transitions. So one of my themes, I always talk ahead of my slides and I'm watching the clock here, but one of my themes is that we really want to build capacity, help people like Tyler to develop the capacity to move along on his own more independently. So I've just listed, not surprisingly, some of the challenges for transition to adulthood. And I think throughout the world, work, employment, or even for individuals who may have less capability, the idea of meaningful participation. What would a 20 or 25-year-old find meaningful in their life, even though perhaps some of their communication or cognitive abilities are limited? And I think that's an extreme challenge. This is a concept we've used in some of our work at CanChild, is this concept of falling off a cliff, that suddenly you're released from the supports of the education system, from the supports of the pediatric healthcare system, And then what do you do? What are some of the perspectives that youth have shared? So these have been directly from them. From the work that's been done, this project by King, they have the same dreams and aspirations as other young people. They also, youth with CP, identify being believed in, believing in yourself, and being accepted by others as important for success in life. Certainly Tyler believes in himself. And then social self-efficacy was, in one study, was associated with independence and persistence among adolescents with physical disabilities. We've done a couple of qualitative studies as part of a large longitudinal study of adolescents, and we focused on 17 to 20-year-olds, thinking they could reflect back even on the early adolescence and maybe share some of their perspectives. So with respect to mobility, what they told us is mobility to them was the safest and most efficient method in a particular situation. It's contextual, so people with cerebral palsy often have several different methods of mobility based on the context. Keeping up with friends and not having to rely on others for assistance, that was important for their mobility. And then it was influenced by physical capacity for sure, but also environmental and personal factors. And that these factors change over time. So I was like, if you think about a preschool child and being independent in an education setting, it's a little self-contained class. Well, what about a university student and having to navigate through a campus? So the environment changes, and I think that are some of the considerations in terms of enabling mobility. Social experiences. They talked about the importance of doing things with friends and being able to make choices and develop strategies for participation in social activities. They talked about trade-offs, problems, solutions, challenges, but opportunities, and that they said they often felt they had to figure things out for themselves. They talked about barriers, of course, physical limitations, some like shyness, but they said many of the barriers were to participation they felt were environmental, and attitudes of others in particular was a theme that these youth talked about. So a couple of quotes just to give you a flavor. I started to think about, wow, doing good in all my classes. I actually do have a future, and I'm going to be able to go somewhere in my life. So I better start thinking about what and where I want to go with it and what I want to do. Another youth said, I was always afraid to ask people to help me because I don't want to bother them and stuff like that. But I've learned to be able to go up to people and just ask them for help. So that's the idea of self-efficacy or self-determination. So the question for us is, are our education and rehab programs preparing children and youth for adult roles and life choices? And I would argue, is this beginning at a young and early enough age? An article that's a seminal article that's been around many years by Suzanne Campbell talked about therapy programs that last a lifetime. And so she addressed some of the avenues or some of the areas that I think now are becoming more understood or more that we're thinking about more. And that is, do young people have knowledge of their disability? Can they explain it to their peers or to other people? Do they have health and wellness behaviors? So that would include prevention of secondary problems, management of medicine or other kinds of medical interventions, and their physical fitness and emotional well-being. Parents of adolescents and young adults, when asked to reflect back, had this advice to share: do not do for them what they can do for themselves, assign appropriate household chores, and help children interact with others in varied settings. So in thinking about the transition process, I do believe that in part it is a systems or resource issue. So as providers or as education program, I think we can prepare and help and advocate people so we have many more young adults like Tyler, but they are bigger issues. So big one we already touched upon is the adult health care system is not prepared to serve. The term that's used now is adults with childhood onset chronic health conditions. So that would be the array of developmental disabilities. Similarly for work, it's a huge challenge, and some of the things for us to think about are the skill development. Are we preparing people at a young age so they can have the skills for work, transportation, accommodations for work, and support to employers. So in the U.S., we do have some services, and sometimes we call them job coaches. But I think in some ways it has gone beyond that because employers, there needs to be a sensitivity. Of course, there's a concern initially that maybe this isn't going to be as productive. And the challenge has been once some of the public monies are removed, will they continue to employ people with disabilities? So support to employers, I think, is probably very important, particularly, as we go through a transitional period, and perhaps 20 or 30 years from now, we can look at that with the success, although not perfect, but the success of including children in regular education. And of course, availability of housing outside the family and attendant care. So what's the vision? A life course approach. Coordinated and comprehensive health services and community supports throughout the life course for individuals. And I think the immediate message probably is that we really need to begin, I think, starting in how you interact with children in preschool to prepare them for the self-determination, for making the choices, so that you do have individuals who are able to advocate for themselves, just as Tyler is able to do. So what about evidence to practice? Yesterday's presentation was excellent, and I think I can play off of a little bit, some of that. So sometimes we feel like we're straddling the evidence to practice gap. The latest research shows that we really should do something with all this research. So Iona Novak's systematic review, I'm not wanting to present it or touch on it so much as to tease out all the interventions, but to perhaps look at some of the other issues for moving forward. So in this review, there were 166 studies and 64 different interventions and 131 outcomes. And as we talked about yesterday by Dr. Green, 24% were graded green, do it, based on the strength of research evidence. 70% were graded as probably do it, yellow, meaning we need to think about other factors, and 6% were graded as don't do. Now, the point I wanted to make is these 9 interventions are interventions at the level of body function and structure. What's notable is the evidence is that they impact upon body function and structure. And that's not a bad thing, but it does leave us wanting to know to what extent are they impacting upon activity and participation. My take-home message, if you, from the previous slide for physical fitness, is the importance of physical activity for children and youth, especially those with limited self-mobility. And it's just beginning to some work, but some research is beginning to look at issues that adults in more industrialized societies face where we may not be as physically active. In other words, risk for obesity, risk for hypertension or cardiac. It's that type of research is just emerging and may further then help to stress the importance of physical activity, which is something we perhaps in the past really didn't think so much about. Now, the other area of review were activity interventions. And so you could see there were 6 interventions that were rated as do it, but only one had even probably in terms of how it is impacting upon children's participation. So the conclusion in the systematic review, only 5% of targeted outcomes addressed participation, and that, to quote, there were no proven effective interventions addressing participation, environmental, or personal factors. And those are our new horizons. So there is a gap in the ultimate goals of pediatric rehabilitation to promote meaningful participation and quality of life, and knowledge of effective services and supports to achieve these outcomes. What about transformative services? The term paradigm shift is often being used in literature to talk about a profession or a society making changes, doing things in new ways. So I've thought about what are some of the factors that may lead us to paradigm shift. Is it research evidence, new ways of thinking, family advocacy, advocacy of youth like Tyler, public policy, and costs and resources? And we're, of course, always mindful of the fact that that is often a huge consideration in terms of services and supports that are available. So I'm going to propose this paradigm shift. And I don't think it's just me, but others certainly as well. But a shift towards family, professional, and community partnerships. Partnerships that focus on children's activity and participation in daily life. And that rehabilitation interventions are goal-directed, strengths-based, solution-focused, and emphasize learning opportunities in natural environments. In a recent study of 501 parents of children and youth, so they range from 3 to about 18 or 19 years, were asked to complete a family needs survey. And I've listed here 5 of the needs that over 50% of families expressed. Information about services in the future, that anticipatory guidance, that planning ahead. Information about services presently available. What can I do to help my child? That's a theme the parents were telling us. Information on planning for the future, guardianship, trust funds, transition to adulthood. In terms of all the literature on family-centered or how pediatric rehabilitation providers do, overall families actually have rated high satisfaction, but the area they continually say we fall down in their eyes is providing them information that is usable for them and is addressing their needs. Help in locating social, recreational, and leisure activities. That's that community partnership. And more time for the self, the parents saying that. So what do we know about family-professional collaboration? It's sort of like family-centered care, right? Of course we all do it. Of course it's a great thing, but it's actually a fairly complex process. Here are some studies and some of the summary points. What are families' perspectives when asked about working with your professionals? Communication is most important. And consider the family in the context of their broader lives, and provide services that address the unique needs of my particular family. Now, what have the professionals said? They've said, well, we see our primary role as services and information relevant to the child's health condition, and it's a challenge to provide responsive, flexible interventions and supports to meet the family's changing needs, because it's not a constant. So I think what it points out is that the idea of collaboration, the idea of listening, the idea of communicating is not so easy as we think, and that as professionals, our perspectives may be slightly different than families. And to the extent we can sort of bridge that gap, it doesn't mean we don't have differences. I think that then allows a true collaboration with regards to meeting children's needs. What is some of the research evidence? Now, this goes back to some of the articles on activities that were cited as do it in the review by Iona Novak. Functional goals achieved following therapy in which parents were involved in goal setting, planning, and interventions were provided in meaningful environments. And then another study, children who received home occupational therapy characterized by mutually agreed upon goals and therapy activities supported by best evidence demonstrated higher goal attainment compared to children in the control condition. So the idea of strengths-based intervention is that build on the strengths of the child, family, and community, build new strengths, and then strengthen the larger social environments in which children, families, and communities are embedded. So it's always interesting as us as direct providers, perhaps, as opposed to public health or perhaps policymakers. But what is our role? What is the role of families? Because a lot of the things that I am talking about really extend beyond what the individual practitioner does. So what are some implications? Do we ask and build on what the child does well? And Peter Rosenbaum, one thing I've learned many things from him, but one, he's a developmental pediatrician, and he would always come to an encounter, a session, child and a family, he'd ask the family, the parent, tell me something your child really does well. What do you want to brag about? And if you can imagine, I think sometimes families they didn't know what to say because they weren't used to that. They were used to the focusing on what the child can't do. And not that that's not important in a medical encounter, but the idea is, do we build on strengths? Do we identify strengths and try to accentuate them? Solution-focused interventions, again, it seems like a very practical idea. And I'll talk a little bit more about this in the next presentation, but the term we've used in our model for participation is what needs to occur to achieve the desired outcomes. So what needs to occur could be changes in the child's physical or cognitive abilities, but it also could be other changes in respect to family and environmental factors. The other thing is, for solution-focused, is who's responsible? So as we move from the concept of a therapist or a professional doing something to a child, and it's not to say that that's not appropriate at times, but the broader picture is doing things or supporting children and families. So the point is, do you delineate what the professional's role will be and what will be the unique role of the youth and the family? What's Tyler's role? You didn't see the video when they showed how he did his martial arts on his knees, but what's his role? And I think that in solution-focused interventions, and what the idea is that we're often collaborating, but do we clearly enough identify the roles that we're all playing and the roles of maybe community partners, such as the coach on a sports team? And then natural opportunities. So a couple of studies, many of these have been in early intervention, talk about the importance of activity settings that provide natural opportunities for children to learn social roles, cultural values, and skills. Personally, I often think the idea of looking at the amount of therapy I appreciate that's a cost, But to me, it's misleading. It's really not the amount of therapy that leads to change. It's the combination of the guidance the professional may provide with the opportunities and the practice that's occurring in the real world settings. And I think we often don't consider this. And so I think that's why sometimes we're in a conundrum in terms of trying to equate that hours of therapy with outcomes. And the rationale, of course, for doing things in natural environments, it's really the basic concept of specificity of learning, which we know across many types of tasks, that the closer you approximate the skill and the target conditions, the better you learn. So very simply, walking upstairs in a therapy clinic is a good way to start, but really you need to generalize and practice that in context of environments where there are stairs or curbs to climb up. So a recommendation by Diane Damiano, whose voice is well known internationally in rehabilitation: therapists need to identify more ways to help children incorporate activity into their lifestyles. And that activity can and should occur in natural, everyday settings wherever possible. So new horizons, abilities, not disabilities. So the question, I think, the challenge we all face is how can we best partner with families and children to provide them support to learn skills, not only those that enable meaningful participation as children, but also that as adults will help them to be healthy and ready to live, work, and enjoy life in their communities. Thank you.
Thank you very much. We have time for questions if anybody wants to ask. Go ahead to the microphone.
Hi. Thank you for a very meaningful talk. It has been a pleasure. I wanted to ask about the interaction of the society and the integration of these children that we all deal about. Do you think that as providers, should we touch base with the government for issuing more money in order for the integration of those kids? Because once looking at Tyler's advocacy, I think that we are the disabled and not him.
And I would probably, so that's a great question. And I would say my understanding is that some of the Scandinavian countries, like Norway, I think have actually provide a model where there is a lot of social advocacy at the society level. So I do think that's very, very important. And I do think some of the changes that have occurred, I think have not been as much in terms of attitudes. I think it really reflect people like Tyler and parents who have taken the effort and really have presented the concerns or the aspirations of people with disabilities. So I do agree that's one of the things as professionals we would like to try to, I believe we can advocate for. Policymakers become a very important in terms of some of the things we're talking about.
Do you think there's a good way of integrating those kids in regular schools? So all the kids will know that those are special kids and not disabled or different, so they know how to deal with them in a matter of environment.
So yeah, the idea of inclusion at a young age. And of course, there are always exceptions. Children are individuals, but as a general idea, what we do know is at young age, children, if nothing else, are curious. So I remember a young boy who had a muscular dystrophy, and he was first presented his wheelchair when walking was no longer feasible. And how would you approach that? Well, you could not talk about it, but if you talked about it, and guess what? Suddenly he was very popular because one, they let other children try the chair, and two, everyone wanted to be his support. So I think young children. And in my second presentation, I'll share with you 12-year-olds and how they responded to having a young man, much like Tyler, in a youth group. So I do think that is one of the thoughts about early integration or early inclusion, that people are understanding. I think sometimes the barriers are not ones of being mean, but people not really knowing how to approach someone with a disability.
Thank you very much.
Gary? Gary?
Hi. Bob?
Yes.
Here. Over here. Hi. Really enjoyed your talk, and you lent us great insights into what it means to work with handicapped children. I think there are two big problems that that primary care physicians find in their work with handicapped children and their families. Number one is being able to help them access to allies in the community. Unfortunately, not enough general care pediatricians and even developmental pediatricians are there for the families and know how to guide the families and help them access the proper services. So there's a big problem within the primary care medical community, even though the American Academy is making great strides in attempts to address the problem. That's one thing that most of the families are very concerned about. And number two is the whole issue of transition from childhood and adolescence into adulthood and continuity of care. It's not clear which pediatricians should continue their guidance and active role in the care of the child or adolescent or young adult once he reaches the age of 18 or 21. It's important to emphasize the continuity of care, the advocacy, and the guidance having to do with enhancing participation well into the 20s, 30s, and 40s. Would you care to comment on some solutions for these two problems?
Well, first of all, thank you for sharing those. I think those are very good insights. And I wish I had great insights myself, but I do think it is a process and it needs to begin somewhere. And then I think, as I said, 10, 20 years later, you may look back and say, wow, what we've accomplished. So I think if nothing, well, the one I think at the individual level is we work, and are we having children make choices? Are we having them learn to talk about their disability, to explain to others? So we all can do it at the individual level, but I think then, as you point out, societal-wise, and it's a resource issue, that is, I think, a challenge around the world we're all facing. In the States, we're starting to see a few model programs. Ontario has one, too, where in Toronto, Blue Review Children's Hospital, which is a leading children's rehab, and then Toronto Rehab Hospital for adults. Luckily, they're next to each other, and they've been starting with a transition where a couple years before a child ages out of the pediatric system, they're building on that. But it's still somewhat limited. But I think those are the kinds of partnerships, is can we form partnerships with adult providers, because the concept of the clinics that we have for children really don't exist, so that they can be comprehensive and supportive. So I think few of the children's centers in the United States have, one in Minnesota has extended and now has an adult facility that they provide to adults. So those are, at least in North America, some of the early. So in some cases, I think a model program is useful to establish and to sustain it, and then that becomes a benchmark by which smaller communities and others can begin to do that. So it's a big challenge we all face.
Thank you.
Thank you very much. Okay, and we move on. Our next speaker is Professor William Dobbins. We heard his excellent lecture yesterday, and looking forward to hear what you have to say today about size matters, the genetic basis of human megalencephaly. So, Professor Dobbins.
This is 30, correct? Good morning. Let me just get organized for a moment here. Again, as yesterday, it's a real pleasure to be in Israel, the most interesting country in the world. And one of the things I'm most pleased about is there's no rumor that the Israeli National Transportation Group is going to go on strike again. So hopefully I'll be just fine. That's what I worried about the most from my last trip. Anyway, so yesterday I talked about severe neurodevelopmental disorders like Rett syndrome and many others, autism, infantile spasms, and other severe early onset epilepsies, which cross a very, very large swath of childhood developmental brain disorders. I'm going to be focusing on a subset that by many is thought of as rare, but I'm going to try to throw in between some of my comments the idea that these are not rare, that the disorders of brain growth that I'm going to be talking about today are associated with severe outcomes in some children, with severe early onset epilepsy in many, and with autism in some. So for example, children with autism who have head sizes larger than +4 standard deviations frequently have mutations of PTEN, which is closely related to the disorders I'm going to be talking about today. With that, let me go on and talk about this swath of developmental disorders that I've been studying for many years now. This is actually what my lab is working the hardest on over the past several years. So it all began, as it often does, with physician researchers in clinic when I was at Riley Children's Hospital in Indianapolis, Indiana, in the States in early 1990. When the senior clinical geneticist, Dr. David Weaver of Weaver syndrome, was on a sabbatical in Australia, and his junior trainee had a very interesting patient who you see in the images on the right. So she actually called me to walk down to clinic, and over the next hour and a half, we sat there just looking and touching this child in sort of amazement because neither one of us had seen anything like this before. We talked to our colleagues, and within a few weeks had found a second and brought them both back into clinic. These are two unrelated boys you can see on the left of this screen. This is Craig on the larger child here. He had a very large head size. He had a few subtle birthmarks. He had very, very soft skin. He was very handicapped. Over the next couple of years, we found 10 to 12 patients from geneticists all over the US and Canada and published a paper back-to-back with a British paper on the same disorder, defining something that we then called the macrocephaly cutis marmorata telangiectatica congenita syndrome that has been more correctly named megalencephaly capillary malformation now. So that was published in, I think, 1997. And here are the features. Look at the overgrown face, but particularly the facial hemihypertrophy. You can see hemihypertrophy of his right body causing a scoliosis. Also, there's very prominent capillary malformations that you should be able to see better on one side than the other, although I have a little trouble seeing it in the bright lights up here, over here. Prominent capillary malformations over the glabella or over the midline philtrum are very, very common. They may have polydactyly, or they may have webbing of the fingers or syndactyly, and they do not have Ehlers-Danlos syndrome or severe connective tissue problems, but their skin is very, very soft. So some years later, I had a medical student who's now turned into a junior faculty member in Seattle. Her name is Reda Mirza. She actually was born in the States, grew up in Bahrain, and is now back in the States, really working as my number 2 person on this project. Actually, she's doing most of the work, which is what you like when you're at my stage. Anyway, I handed her this project as a medical student, and a couple of weeks later, she handed me a near-finished draft of a new syndrome that we called megalencephaly polymicrogyria polydactyly hydrocephalus syndrome. It's really very much the same as the first syndrome I showed you, but they don't have any skin or other changes outside the brain except for occasional polydactyly. These two syndromes prove to be relatively common. Their head size is large, their body size, their length and weight tends to be normal, but their head size is not. So in this paper that Rader published in 2012, she did a careful head size curve. What I want you to see is that a few patients have normal head size or only mildly large head size at birth, but by the age of about 1, they are typically larger than +3, and most are larger than +4 standard deviations. So they have very large head sizes. So just to give you some aspect of how common this is, macrocephaly is common. So hydrocephalus is a rare cause of large head size. Most children with large head size have large brains. So if you define it as +2 standard deviations or larger, it's 2.5% of the population. That's a little soft. So if you define it as +3 standard deviations, then that means that 0.13% have macrocephaly, with the vast majority megalencephaly. If you take the population of Israel, which I just looked up as 8 million, that means that 10,400 individuals in your country have megalencephaly. I'm not saying they all have mutations of the pathway I'm talking about, but some of them certainly will. The manifestations here are protean, and so any clinic you happen to go to, certainly in a children's hospital or children's clinic, you are likely to see at least some of these phenotypes. Mental retardation or intellectual disability is common, and it varies from severe to minimal. Seizures are common, as is autism. The seizures are often among the most severe we ever see, including infantile spasms. For neurosurgeons, hydrocephalus is common, as is Chiari malformation and syringomyelia. How are those linked by a single gene? Cardiology, I have had sudden unexpected death in epilepsy, as well as cardiac dysrhythmias. Vascular anomalies or cardiovascular anomalies are less common but occur. There's lots of skin abnormalities. Obstetrics, obviously these children can have very large head sizes, which cause lots of troubles during birth. Oncology. This is not widely recognized, but there appears to be a slightly increased risk of Wilms tumor in children with mutations of these genes, or with these syndromes. And you can see some of the other disorders. Virtually every system that you can think of can be affected by this class of disorders. Here's one. So you can see the ventricles here look somewhat large, so they are hydrocephalus, and the one in the lower right has been shunted. So what we actually found, and this is data from Brada's 2012 paper, ventriculomegaly in 81%, hydrocephalus defined as a neurosurgeon placing a shunt in 40%. So it's a common manifestation. So too is Chiari. So in the neurosurgical literature, the best understood pathogenesis of Chiari malformation is a normal brain with a normal cerebellum in a small posterior fossa. But turn that around. What happens if you have an abnormally large cerebellum in a normal posterior fossa? It's the same thing. And when you talk to neurosurgeons who are expert in Chiari, they will tell you that sometimes they see a posterior fossa that is too large and they don't really understand why or how the child gets Chiari. Perhaps you can now. Here's one example of a megalencephaly with a very large cerebellum squeezing down into the upper cervical cord. Here's a second unrelated child. Here's a third. This is quite common. And so of those two syndromes that I described initially, MCAP and MPPH, it was some pushing down of the cerebellar tonsils into the low part of the posterior fossa was seen in, let's see, 27 out of 40. What is that? That's a lot. That's more than half, 2/3. That's not Chiari, but it progressed in 7 out of 27, which is about 25%. That's Chiari malformation. And several of those children had posterior fossa decompressions. So Chiari malformation is relatively common. I don't have good numbers for syrinx. It's less common than Chiari, but it certainly occurs. Sometimes you can recognize this because the corpus callosum gets massively enlarged. Perhaps more importantly, many of these children have a cortical malformation that looks like polymicrogyria. It's often asymmetric. You can see mild, severe defects in this child with here, and a mild change over here. When you look at other children, Here's an example. You see some less severe PMG that is symmetric here and over here. Okay? Same thing here and here. It can be relatively subtle. Certainly this is associated with increased risk for epilepsy. All right, so we have 2 syndromes so far, 2 and counting. Here is the MCAP syndrome, in which there's the vascular malformations or the capillary malformations of the skin, extra fingers, polydactyly, tissue webbing, syndactyly, and many other features. And here is what the children look like with just the brain alone, although some of them have a 6th finger. MCAP and MPPH. All right, I thought that these were 2 separate syndromes, but wasn't sure, so I compared those children with the skin abnormality versus normal skin with the fingers. When you look at any finger anomaly, either a 6th finger or the tissue webbing, the syndactyly, I found no significance. But when I compared the vascular malformations of the skin with the tissue webbing or syndactyly, down here, somewhere at the bottom right, if I can get my cursor to work, which I could not, it's the bottom right, you see a highly statistically significant association. And the same thing was seen with somatic or body overgrowth, particularly hemihypertrophy. So I thought they were 2 syndromes that I defined as you see here. So I used these and sent, back in the days when exome sequencing was just becoming available, I sent off 4 families. Here is one of the first with MPPH. We found de novo sequence changes in 2 children with in the AKT3 gene. I'll talk about that gene in a little bit. At first, we didn't believe it. I didn't believe it in particular because I had published a paper showing that deletions of AKT3 cause microcephaly. Here's one example of a child with a very small deletion of just AKT3 who had significant microcephaly, brain too small. But of course, this was not a deletion or inactivation of the gene. It was an intragenic mutation that could be either a loss of function or gain of function. There was already evidence that other proteins could have, or this gene could have a gain of function. So here is a similar mutation in a mouse model that was already available in the literature. It was described as an epilepsy mouse model, but if you look even very quickly at the mouse's brain, you'll see that the mutant had a very, very large brain, megalencephaly. In addition, a related gene called AKT1 had recently been shown to be a gain-of-function mutation's cause of Proteus syndrome. And just a month or 2 before our paper came out, Ann Poduri et al. From Boston Children's showed the mutation of this gene in hemimegalencephaly, a cause of severe childhood epilepsy. So that's one gene. We then started focusing on that pathway, and in a family with 3 affected children, which is very rare, we found autosomal dominant or heterozygous de novo mutations in all 3 children, suggesting a mosaic mutation in the parents, either in a gonadal mosaic mutation in either mother or father, because in blood, the mother and father were normal. In a different gene that is a regulatory unit of this pathway, we found a recurrent mutation, the same mutation in, at this point, I think 11 children, and it's now up to about 19. Finally, we turned to the MCAP, the more severe syndrome with the syndactyly and skin changes, and found mutations of a gene called PIK3CA. However, these were different because the mutations were not seen in every cell, but somewhere between 5% and usually 30% of cells, indicating a mutation occurring after conception, a postzygotic or mosaic mutation. And each time I talk about a mosaic phenotype, I'll have a little red triangle in the lower left corner. All right, so we had 13 mutations out of 22, and overall, we found mutations in one of these 3 genes in 75% of our patients with these 2 syndromes. At the same time, Dr. Joe Gleason's laboratory demonstrated mutations of the same genes, PIK3CA and AKT3, in hemimegalencephaly, a cause of severe childhood intractable epilepsy. These are the 4 with the PIK3CA mutations. All right, so here is the pathway. What I want to point out here is we'll later be talking about RTKs because these are receptor tyrosine kinases that start the whole process of this signaling pathway. Here is PIK3CA and PIK3R2. Here is AKT1, 2, and 3, and for us, AKT3. And there are some other, here is tuberous sclerosis, and here are some other megalencephaly genes down here that I'm not going to focus on today. So I want to have time to sort of get to 45. I'm just calculating time because this was not set quite right, 15 minutes. All right. So what I want to do here is to focus on some of the broader phenotypes we see and then spend a little bit of time, actually more than a little, on ideas of how we can actually treat these children, a novel concept. All right, so here we have a range of disorders, clinical disorders, that have all been described separately as different diseases by different clinicians, both involving the brain and the body. For example, Klippel-Trenaunay-Weber syndrome, now called Klippel-Trenaunay syndrome, Cloves syndrome, and isolated enlargement of the fingers. So here is Cloves syndrome, which is a striking body overgrowth syndrome with lymphatic malformations, fatty overgrowth or lipomatosis, body overgrowth, capillary malformations of the skin, etc. This baby looked terrible, although by the time she was a couple of years old, she looked much better after some surgical operations. Her defect started at about the nipple line and went down to her toes. She actually had no phenotype, no overgrowth in her brain, luckily for her. Here is a paper from the Warman lab in Boston demonstrating mutations of the same gene, PIK3CA, the same gene as the MCAP gene in children with Cloves syndrome. They're different mutations, but the same mutations as shown in the hemimegalencephaly. I'll show that in more detail later. Here is a Cloves-like syndrome called fibroadipose hypoplasia that I think is the same syndrome. But if you want to see some really striking overgrowth, look at this woman's foot. This is in the lower left of the image right here. Okay, so that foot is about 10 times as large as a foot should be. Okay, and here is isolated macrodactyly, or isolated enlargement of several fingers, all due to mutations of the same gene, PIK3CA. Here is the most interesting patients I've seen with this, a child who had a mild Cloves phenotype, if you look at the overgrowth of her hands and her feet. But she also has striking enlargement of the brain. This is not just megalencephaly, but it has the severe cortical dysplasia characterized in hemimegalencephaly, but it's on both sides. How can you have bilateral hemimegalencephaly? Here's a child with a PIK3R2 mutation with a typical standard mutation with very large head size and the cortical malformation polymicrogyria. Here is the brain scan of a child with polymicrogyria, a mutation of PIK3CA, normal head size. So it's not just for large head size anymore. And then we go from those obvious brain overgrowth phenotypes to hemimegalencephaly and the related disorder, focal cortical dysplasia. So FCD is a very interesting disorder. It's a relatively common cause of intractable epilepsy. So epilepsy affects something like 1 out of every 200 children. 20 to 30% of those children have untreatable or intractable epilepsy. And of those, some are between, depending on the study, 15 to 40% have focal cortical dysplasia. And half of those are FCD type 2. When you add all that together, focal cortical dysplasia is probably the most common cause of intractable epilepsy in children, and one of the important causes in adults as well. So here are some of the abnormalities that I don't want to focus on, but you can get very large sized neurons. I think this might be a balloon cell, and you can see the large neurons are I think those are balloon cells. I can't see them very well, but these are very large, abnormal appearing neurons. All right, and there are 3 types of FCD with several different subgroups. The type that is linked to the megalencephaly is type 2, FCD 2A and 2B. So here, let me show you what these look like. So on the left, we have a PIK3CA mutation with bilateral severe cortical changes, bilateral hemimegalencephaly that I call dysplastic megalencephaly because, of course, the term bilateral hemimegalencephaly is stupid. On the right, we have hemimegalencephaly, but it's not half the brain, it's the posterior half of that brain. And here is something you have not seen before, not yet reported, although it soon will be by our lab and others. Here's a child with focal cortical dysplasia limited to the occipital lobe with a mutation of PIK3CA. Here it's a little hard to see, but at a lower level, you can see the FCD quite easily, the localized brain overgrowth, right there. This girl is seizure-free following surgical resection of the occipital lobe. Here is a child with an AKT3 mutation, the same mutation causing hemimegalencephaly reported by other groups. You can see the hemimegalencephaly there, but what I want you to focus on is the other side. She's got a little bit of focal cortical dysplasia and the other side, occipital lobe. All right, so out of our first 25 surgical samples, we identified mutations in 4 children. These are limited to the FCD 2A and 2B groups. I do not include FCD type 1 or 3 here. What I want to show you here is the 4 patients with known mutations of this pathway are given numbers, 1, 2, 3, 4. But if you look at all of the FCDs and hemimegs, right, here we go, here, here, and here, they all have increased levels of the activated form of AKT, which is phospho-AKT. So even though we don't know the underlying mutation, it appears that there is abnormalities, upregulation, or hyperactivation of this pathway in all of the FCD 2A and 2Bs. It's actually 19 out of 20. All right, so we have a range of phenotypic disorders here. And again, I want to run along to get to some of the most interesting stuff. So what we have found in our lab is that the common megalencephaly syndromes, MCAP and MPPH, are caused by mild to moderate gain-of-function mutations, while the hemimeg and cloves are caused by severe cancer hotspot mutations in these genes. So MCAP has been caused by mutations. I'm waiting for my arrow. There we go. You can see here, all the way along, we've got lots of different mutations, maybe 20 of them, whereas hemimegalencephaly and cloves are caused by 3 cancer hotspots commonly and 2 other hotspots occasionally. So 4 to 5 mutations cause hemimegalencephaly and cloves. Everything else causes MCAP. These same mutations cause hemimegalencephaly and cloves and the macrodactyly. When you go on to the other 3 genes, particularly AKT3, the same is true. Most mutations are mild gain of function and cause megalencephaly phenotypes, whereas for AKT3, a single hotspot mutation known as E17K causes hemimegalencephaly. So we have a range of cortical abnormalities here that goes from bilateral hemimegalencephaly or dysplastic MEG to hemimegalencephaly that can be most prominent most frontally or posteriorly, to focal cortical dysplasia type 2. Or you can get a less severe but extensive megalencephaly. All right, so what we have then is this pathway. Remember that the pathway starts by trigger with a receptor tyrosine kinase such as platelet-derived growth factor receptors, epidermal growth factor receptors, so EGF and PGGF-A. And a number of others, and right into the pathway. So what I didn't talk about a lot earlier that I showed the sign is there are some specific small molecules or drugs that are known to inhibit these pathways. So when you take a gene and you knock it out, it is hard to replace that gene function. However, when you have excess activation, these are often druggable. And there are a number of drugs, none available clinically at this point, that can downregulate or inhibit this pathway. Some are specific at the Pi3K step, that's for PIK3CA, some at the AKT3 level, and some downstream at mTOR. Many of you will have seen children or known of children treated with everolimus or sirolimus. Many of you would have treated children with this, particularly with tuberous sclerosis. This is also used in cancer. However, in cancer, it controls giant cell astrocytomas in tuberous sclerosis, but as soon as they stop the medicine, they start to grow again. In other forms of cancer, it seems to help a little bit. The mTOR inhibitors have just never been particularly effective in cancers, and there's some question about how effective they are in tuberous sclerosis. But, come on, there we go. All right, so if you look on the left, what you'll see is that this is a paper that shows if you inhibit mTOR with everolimus, turns out you upregulate AKT, which is a more central actor in this whole pathway. Any wonder that everolimus is not working that well? And if you look on the right, you will see that it turns out that this entire pathway is one of the best known pathways in cancer. And even though these children have a very low incidence of cancer, we know a lot about the biology of all of these genes and proteins from cancer research. Here is a very interesting study that showed with, I think, liver cancers, but it's also been shown with some hematologic cancers, that everolimus, the mTOR inhibitor, doesn't do very much. But when you combine an AKT inhibitor with everolimus, an mTOR inhibitor, you get much more effective treatment of cancer. Is the same thing true for these developmental disorders? Unfortunately, none of these medicines are available clinically except for the mTOR inhibitors, such as everolimus. That is not likely to change soon. Some of these are under cancer trial right now, but drug companies are slow, more likely to treat cancer than they are to treat megalencephaly. But in concept, do we have any way to treat both AKT3, to inhibit both AKT3 and mTOR? What I'm trying to get around to is novel ways of thinking about treating disorders here that are considered birth defects, but the brain overgrowth syndromes are certainly more than simple birth defects. All right, so let me turn back to epilepsy. We know a lot more about epilepsy than we do about brain overgrowth, hydrocephalus, and Chiari. Many children with focal cortical dysplasia have severe intractable epilepsy. It's often the most difficult to treat that a neurologist or epileptologist ever sees. So, in this one study from, I think, Korea, but this is similar to experience we have in Seattle, they treated children with 2 medicines and were able to get control in 13%. When they tried a third medication, it worked in 1 out of, I think, 25 children. 1 out of 44 children. Not very effective, 2%. When you tried the ketogenic diet, it worked in 33%. Surgery was more effective. So it appears that the ketogenic diet is not just a reasonable treatment for the epilepsy of focal cortical dysplasia in hemimeg, it is by far the best treatment, overwhelmingly better than medications. Why? So you look in the literature 10 years ago, or 15, nobody knew why the ketogenic diet works. Now there's about 5 or 6 different mechanisms, but there's one that's really interesting. If you look here in the hippocampus, they put a rat on the ketogenic diet. And what they found was that it downregulated, and you can see that right here, the yellow is the ketogenic diet, it inhibited or downregulated AKT. It also downregulated mTOR, downregulated both of them, just like those medication combinations. It wasn't very powerful, but it did it. It actually worked better, more robust in the liver than it did in the hippocampus, so perhaps brain is a little more difficult. So the ketogenic diet is obviously far from an ideal treatment, but in concept, it inhibits both AKT and mTOR. Is that why it works in focal cortical dysplasia? Obviously, the plan would be to go back to the pathway and try some of these different medications. And what would happen if you treated a child with both mTOR and the AKT inhibitor, MK2206? Boy, wouldn't that be interesting? Could it treat the hydrocephalus or the brain overgrowth, the megalencephaly itself? Clearly, we don't know the answer to that, but that's at least the questions raised. So what we have is some apparently rare disorders that actually are more common when you look for them, and that appear to have overlap with things such as megalencephaly, the common less severe forms, Chiari malformation, hydrocephalus, focal cortical dysplasia, and intractable epilepsy, and all sorts of body overgrowth, for example, lymphatic malformations. All of these, affecting so many systems, are potentially treatable. This is a new concept. So rather than, say, treating the epileptic seizures with a Dilantin or some other medication to treat the excitability, an anti-seizure medication, can we find a true anti-epileptic medication that goes directly to improve the underlying basic cause of the disorder? The same could be true for autism, at least when it's caused by this pathway. So there's lots to do over the next 10 years, but this is sort of a proof in concept of what we need to be thinking about in developmental brain disorders. Thank you.
Thank you very much. Any questions? Great. So,
I have a question. Question?
stand up. Go ahead.
In your idea of treating these disorders, how much damage do you think is already present at birth, and are you thinking of prenatal treatment as well?
It's a really interesting question. In the U.S., it's less relevant. We are nowhere near as good at prenatal diagnosis because, of course, of the timing differences. The megalencephaly it clearly progresses rapidly over the first year of life. Many of these children do not start seizing until several months of, and sometimes several years of age. So I think that treatment from birth onward will certainly be effective. Now, could it be even better if you treat earlier? Of course. I think the problem is affecting growth. You certainly will need to be careful because if you block both AKT and mTOR, it would affect probably every tissue, not just the brain. So that's going to be a very complicated question. I think what needs to happen is we need to try these postnatally, preferably in the first year or so of life first, and then extend that to prenatal. Some of these are going to be easy to diagnose, but the PIK3CA mutations in focal cortical dysplasia and hemimegalencephaly can affect as low as 5 and 20% of the cells in the affected brain and none in blood or saliva. So making a molecular diagnosis is difficult, and in prenatal it's going to be, in the mosaic cases, it's going to be more difficult. One of the interesting questions is what would you see in amniocytes or chorionic villi? Really interesting question.
Thank you very much, Professor Dobbins, for both your talks today and yesterday.